Welcome to Prism Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Welcome back to the deep dive. I want you to picture a scenario.
Oh, let me guess. The Monday morning dashboard.
You know it. It is Monday morning, you have your coffee, you are settling in at the clinic, and you open up your software to check the CPAP downloads from the weekend.
And there it is.
Yeah, the messy patient.
The dreaded squiggly line of doom.
Exactly. You know the exact patient I'm talking about. Maybe they have severe heart failure. Or maybe they are on a high dose of methadone for chronic back pain.
Or maybe they just started a standard CPAP for plain old obstructive sleep apnea like 2 weeks ago.
Right. And now you look at their breathing flow, and it looks like absolute chaos.
Yeah.
It is not just a closed airway where they're struggling to breathe.
The signal is just flat.
The signal is totally flat. They're not even trying to take a breath.
You are looking at central apneas.
Central apneas, yes.
Yeah.
And maybe you even see that really classic waxing and waning pattern.
Cheyne-Stokes
respiration, exactly, where the breathing builds up, gets really loud and deep, and then just fades out into nothing like a sine wave.
Over and over again.
Over and over. And the big question hits you as a clinician. What on earth do I do with this?
Do you turn the pressure up?
Right. Or do you turn it down? Do I try to switch them to a $5,000 advanced ventilator?
It's frustrating.
It is so frustrating. You sit there wondering, are we just treating a number on a computer screen, or are we actually helping the human being sleeping in that bed?
That is really the fundamental tension of modern sleep medicine. And usually when we feel that level of uncertainty at the bedside, we turn to the clinical guidelines.
We want a recipe book.
We do. We want someone to tell us, if X happens, then do Y.
We want the certainty so we know we aren't messing it up.
Well, I have to set the stage here today with a bit of a reality check for you. We are unpacking the brand new guideline on this exact topic. And if you are looking for a black and white recipe book, you are going to be a little disappointed.
Oh, really? Why is that?
Because this document is absolutely dominated by conditional recommendations. The evidence backing almost everything we're going to talk about today is graded as low or very low certainty.
Wow. So we are really navigating the gray zone today.
We are deep in the gray zone. But that does not mean we are flying blind. It just means the rules of the game require a lot more thinking.
And a lot more conversation with the patient, I imagine.
Exactly. It forces us to stop being technicians who just try to fix an AHI number and start being actual clinicians who treat a complex human being.
I love that. But before we get deep into the weeds of pressures and waveforms and advanced servoventilation, we do need to handle the official housekeeping.
We definitely do.
Go for it.
This is the American Academy of Sleep Medicine Clinical Practice Guideline on Central Sleep Apnea, published in the Journal of Clinical Sleep Medicine in 2025.
Perfect. And as always, we have a mandatory disclaimer for you. This discussion is for educational purposes only and does not constitute medical advice.
Please do not change your ventilator settings based on a deep dive you listen to.
Yes, if you are a clinician, use your independent clinical judgment. If you are a patient, talk to your doctor.
Leave the settings alone until you have spoken to your provider.
Absolutely. Okay, so our mission today is to parse this specific 2025 PDF guideline.
And only this guideline, we are sticking to the text.
Right. No outside hallucinations or pet theories today. We are going to strip away that old school event elimination mindset.
You mean just trying to get the apnea-hypopnea index down to 0?
Exactly. We need to look at what this guideline actually says about patient-centered care. We are going to build a clear hierarchy of treatment for you, starting from the basic stuff all the way up to advanced therapies like phrenic nerve stimulators.
But we have to start by defining the beast itself. Because central sleep apnea, or CSA, is not just one uniform disease.
It is definitely not just obstructive sleep apnea's quiet little cousin.
Not at all. It feels very different clinically.
It does. Think about obstructive sleep apnea, or OSA. The drive to breathe is completely intact. The brain is literally screaming at the lungs to breathe.
But the pipe is blocked.
The throat collapses. It is a mechanical plumbing failure.
Right, the effort is there, but the airflow stops.
But in central sleep apnea, the pipe is usually wide open. I mean, you could drive a truck through that airway.
The problem is the driver.
Exactly. The brain just stops sending the signal to the breathing muscles.
So by definition, you have a lack of respiratory effort coupled with a cessation of airflow.
It is a complete pause, a system failure at the source.
And to understand why that happens, you really have to look at the physiology of instability. This is honestly where the science gets fascinating.
Walk us through it.
Well, when we are awake, like we are right now having this conversation, we have what is called a wakefulness drive to breathe.
It keeps us breathing no matter what.
Right. It overrides a lot of our underlying chemical sensors. You can just choose to hold your breath right now, or you can choose to hyperventilate, regardless of what your blood oxygen or carbon dioxide levels actually are.
So the conscious pilot is sitting in the cockpit flying the plane.
That is a great way to put it. But the moment you fall asleep, that wakefulness drive simply vanishes. The conscious pilot leaves the cockpit entirely.
We go straight onto autopilot.
We do. And the autopilot does not care about your day or your stress or your choices. The autopilot only cares about one thing.
Chemical levels.
Specifically, your carbon dioxide levels, PACO. During sleep, respiration becomes critically dependent on CO2.
Okay, and that introduces the concept that I think trips a lot of people up, the hypocapnic apneic threshold.
It sounds like a terrifying medical buzzword.
It is a mouthful. Let's unpack it for the listeners.
It sounds complex, but it is actually a very simple concept. Think of the apneic threshold as a floor.
A hard floor.
Yes. If your blood CO2 levels drop below that specific point, that floor, your brain just shuts off the breathing signal.
It just tells the diaphragm to quit.
Right. The brain says, hey, we don't have enough CO2 floating around, so we must be overbreathing. Stop breathing immediately until the CO2 levels build back up.
So paradoxically, the apnea, the lack of breathing, is actually caused by breathing too much right before it happens.
Precisely. The hyperventilation causes the apnea. And this brings us to an engineering concept that is really central to this guideline, loop gain.
I know you love a good mechanical analogy for loop gain.
I do. I always use the thermostat analogy. It works perfectly.
Let's hear it.
Imagine you have a thermostat in your house, but it is incredibly overly sensitive. We call this high loop gain in physiology.
So it reacts too strongly to everything.
Exactly. If the temperature in the house drops by just 1 single degree, this high loop gain thermostat panics. It blasts the furnace at absolute maximum power.
So the house instantly overheats. It gets sweltering.
Right. And because it overheats so fast, the thermostat panics again. It shuts off the furnace and blasts the air conditioning at maximum power.
Now you are freezing.
And the cycle repeats forever. You are constantly oscillating between freezing and boiling. You literally never reach a stable, comfortable temperature.
And in the human body, boiling is hyperventilation.
Exactly. A tiny little disturbance, maybe you toss and turn or have a tiny arousal, makes you hyperventilate. You take huge, massive breath. You blow off way too much CO2.
And when you blow off that CO2, you hit that floor.
You drop below the hypercapnic apneic threshold. The brain slams the brakes. The furnace shuts off. That is the central apnea.
So the pause in breathing allows the CO2 to slowly build back up.
Yes. It builds up during the apnea. You eventually wake up or have an arousal from the lack of air. You panic. You take a huge breath. You hyperventilate again. And the entire cycle just repeats.
Wow. This is why the guideline heavily emphasizes that most central sleep apnea is actually a post-hyperventilation phenomenon.
That is the exact term, post-hyperventilation.
It's a massive reframe for how we think about this. The apnea is not the primary event. The instability is the primary event.
Correct. The pause is just the body's overreaction to the instability.
But this does not apply perfectly to everyone, right? I mean, we see central apnea in heart failure patients all the time, but we also see it in young people on high doses of opioids. Is the mechanism identical?
Not at all. And this is where we use the term equifinality.
Equifinality.
It basically means that different roads lead to the exact same destination. You look at a sleep study report and you see a central apnea. But how that specific patient arrived at that apnea matters immensely for how you treat it.
Let's break down those roads. Start with the heart failure road. That is a huge chunk of our clinic population.
In heart failure, you generally have two compounding problems. First, you have a circulatory delay.
Because the pump is broken.
Right. The heart is weak, so it takes a very long time for the blood to travel from the lungs, where the gas exchange happens, up to the chemosensors in the brainstem.
So the brain is constantly reacting to old news.
Yeah.
It is getting delayed feedback.
Exactly. And the second problem is that those sensors in the brainstem are hypersensitive.
That is the overactive thermostat again.
Yes. Increased chemosensitivity plus delayed feedback leads to a massively high loop gain that creates Cheyne-Stokes respiration, that classic slow crescendo-decrescendo breathing pattern.
Okay, now compare that to the patient on chronic methadone or fentanyl.
Totally different road. Opioids directly depress the central respiratory drive. They just make the whole system sluggish and lazy.
So it is not an overreaction.
No. Unlike heart failure, opioids often decrease the chemosensitivity. So you have essential apnea because the drive is literally drugged into submission, not because the system is overreacting and oscillating wildly.
And what about high altitude? The guideline covers that too.
High altitude is fascinating. You have hypobaric hypoxia. The lack of oxygen in the thin air constantly drives you to hyperventilate,
Which blows off CO2.
which drops you below the apneic threshold as soon as you fall asleep.
And yet on the final sleep report on my desk, it usually just gives me one number, the Central Apnea Index.
Which is extremely frustrating. That is why the guideline uses the ICSD-3TR categories to try to split this up.
What are those specific categories for the listeners?
Primary CSA, CSA with Cheyne-Stokes, which is usually your heart failure group, medication or substance-induced, medical disorder without Cheyne-Stokes, treatment emergent, and high altitude.
Treatment emergent is the one that drives clinicians absolutely crazy.
TEXA.
Yes, TEXA. You put someone on CPAP for obstructive apnea, you fix their snoring, and suddenly their brain just stops initiating breaths.
It used to be called complex sleep apnea, and honestly, differentiating all these phenotypes clinically is really hard.
The guideline actually calls out how hard it is, right?
It does. It notes that without an esophageal pressure balloon to measure actual pleural effort.
And let's be real, practically nobody is using esophageal balloons in a standard sleep lab. It is incredibly invasive.
Exactly. Nobody does it. But without it, it can be nearly impossible to definitively tell a central hypopnea from an obstructive hypopnea on a standard tracing.
Because mixed disease is so common. You have a floppy airway and a hypersensitive brainstem at the same time.
It is very messy.
Okay, so we are dealing with a mixed bag of etiologies. Let's talk about the rules of engagement here. How did the AASM actually write this? They didn't just put a bunch of famous doctors in a room to shout opinions at each other.
No, they used a very rigorous framework. They used GRADE.
Grading of recommendations, assessment, development, and evaluation.
You got it. It is a highly structured methodology. The task force did a massive systematic review of the literature with a cutoff date of February 2025.
And what I found really interesting is that they did not just look at the AHI, they cared about other things.
This is a major, major paradigm shift. In the old days of sleep medicine, if you got the AHI from 40 down to 5, you won. High fives all around, send the patient home.
We treated the chart.
We treated the chart. But this 2025 task force prioritized completely different things. They prioritize excessive sleepiness, sleep quality, cardiac outcomes, hospitalizations, and mortality.
Real human outcomes.
Yes. Now, they still looked at disease severity metrics, things like the AHI, the Central Apnea Index, the Oxygen Desaturation Index, but they viewed them as measures of severity, not as the only endpoints that matter.
So what did they find regarding the actual certainty of the evidence we have? Because we have been treating this for decades.
Honestly. It is incredibly sobering. When you run the literature through the strict grade criteria, almost all the evidence discussed in this guideline is graded as low or very low certainty.
A very low certainty for therapies we use every single day.
Yes. We are very, very good at fixing the squiggly line on the screen. The machines work great for that, but we are much less certain that fixing that squiggly line actually keeps people out of the hospital or makes them live longer.
That perfectly explains why we see so many conditional recommendations in this document.
Exactly. When you see a strong recommendation in a guideline, it means just do this. The benefits clearly and overwhelmingly outweigh the risks for almost everyone.
Like giving antibiotics for severe bacterial pneumonia.
Right. But a conditional recommendation means we suggest this. It implies that the benefits do not overwhelmingly outweigh the harms or the burdens for every single patient.
So it requires a conversation?
It requires shared decision-making. I cannot stress that enough. You have to explain the uncertainty to the patient.
Which brings us to the absolute North Star of this entire deep dive. The guideline includes a good practice statement right up front.
This statement is the anchor. It is the lens through which we have to view every single therapy we are about to discuss.
Let's hit the key principles of this anchor, Principle 1.
Individualized care based on clinical features and comorbidities. Don't just treat the CSA phenotype on the sleep report. Treat the actual patient sitting in front of you.
And Principle 2, this is the big one for me as a clinician.
Optimize contributing conditions first.
Yes. So if they have heart failure, treat the heart failure, give them diuretics, optimize their beta blockers, do whatever the cardiologist tells you to do.
If they are on massive doses of opioids, try to taper the opioids or manage that pathway.
Do not just slap a PAPI mask on a fundamental medical problem and hope the apnea goes away.
Exactly. Fix the foundation. If the central apnea is being driven by severe fluid overload from a failing heart, aggressive diuresis might fix the sleep apnea way better than a CPAP machine ever could.
Principle 3 in the good practice statement.
Focus on patient-reported outcomes, PROs.
Are they actually feeling less sleepy during the day? Is their quality of life tangibly better?
Right. If you fix the AHI so the download looks perfect, but the patient tells you they're still completely miserable and exhausted, you have not succeeded. The therapy is not a win.
And the final principle, Principle 4.
If central events persist after you initiate a therapy, you must reevaluate.
Do not just accept a high central index.
Do not accept it. Reassess the risk factors. Consider that maybe your first choice of therapy was simply the wrong one for that specific patient. You have to pivot.
I think we all needed that tension release before we dive into the heavy data.
The rules of engagement are set. Let's get to the therapies.
Okay, let's apply that North Star framework to the actual treatments. We are going to build a hierarchy here. Let's start with the standard PAPI options, the absolute most common tool in the sleep medicine shed: continuous positive airway pressure, or CPAP.
The 2025 guideline gives a conditional recommendation for CPAP.
Okay, hold on a second. We just spent 10 minutes explaining that CPAP is a pneumatic splint for a collapsed physical airway.
A plumbing fix.
Right. If central apnea is a problem with the brain's signal, not a collapsed throat, why on earth are we using CPAP? It seems totally counterintuitive.
It is a really fair question, and it bothers a lot of trainees. But CPAP actually does a few physiological things beyond just splinting the throat.
What else does it do?
First, it physically increases your lung volume. It creates a larger functional residual capacity in the chest.
So your lungs stay a bit more inflated even when you exhale?
Exactly. And that acts like a massive oxygen reserve. It stabilizes your blood oxygenation over time.
Oh, I see. So it prevents those rapid, sudden drops in oxygen that trigger the brain to panic and hyperventilate.
You nailed it. It essentially dampens the oscillation of the loop gain. And second, and this is practically very crucial, many of these patients actually have mixed disease.
They have a little bit of obstruction lurking underneath the central events.
Almost always. CPAP fixes that subtle underlying obstruction, which stops the arousals, which stabilizes the whole respiratory loop.
Okay, so who specifically is this conditional recommendation for?
The guideline lists primary CSA, heart failure, medication or substance-induced, treatment emergent, and medical disorders, basically across the board.
But the certainty of the evidence is low.
It is low. This is based on a summary of 11 randomized controlled trials. Now, here's the real nuance you need to understand. CPAP consistently improves the AHI. It clearly lowers the disease severity metric.
But I hear a but coming.
But in the pooled grade data, it does not consistently meet clinically meaningful thresholds for patient-centered outcomes.
You mean things like excessive daytime sleepiness or overall quality of life?
Right. In the aggregate data, it didn't consistently move the needle enough on how the patients actually felt.
That is a really tough pill to swallow for a clinician. We are fixing the chart, the download looks beautiful, but we might not be fixing the patient's symptoms.
In the broad statistical average, yes. But the guideline still suggests it because it is incredibly accessible, it is relatively cheap, it is very safe, and it absolutely does stabilize the upper airway.
So the implementation pearl for clinicians here is clear. CPAP is the logical starting point simply because we have it.
Yeah.
It is feasible. But you absolutely must verify the response.
Yes, you cannot just prescribe it, pat them on the back, and see them in a year. You need to look at the sleep testing or the detailed device data.
If the central apneas persist on CPAP-like, if their AHI is still 25 and the machine says it is all clear airway central events, it is not working.
The guideline is explicit on this. If CSA persists, consider an alternative. Do not just leave them on failing therapy.
Okay, so if CPAP fails, or if we want to get a bit more mechanically sophisticated right out of the gate, the natural instinct is to move up to bi-level PP. But there are two very distinct flavors of bi-level here, and the distinction is a matter of safety. Let's talk about bi-level with a backup rate first.
Also known as BPST, spontaneous timed.
What is the verdict?
The guideline gives a conditional recommendation for bi-level with a backup rate.
For which specific etiologies?
Primary CSA, medication or substance-induced, treatment emergent, and medical disorders.
Noticeably absent from that list is heart failure.
Correct. The guideline notes there is an evidence gap for heart failure here, so a formal recommendation doesn't explicitly cover HFF, even though we know it gets used clinically sometimes.
And what is the certainty of evidence for the groups it does cover?
Very low certainty. We are looking at only 6 RCTs and 3 observational studies, and the total participant pool across all those studies was extremely small. We were talking about maybe 128 people who actually completed the trials.
128 people total. That is a tiny foundation to build a guideline on.
It is tiny, but mechanically, physiological logic supports it.
Let's explain that backup rate for anyone rusty on their ventilator modes.
It is exactly what it sounds like. You program the bi-level machine to enforce a minimum respiratory rate. You set it to say, if the patient does not take a breath on their own for, say, 10 seconds, I am going to force a breath into them.
It sets a mandatory floor for ventilation.
It does. It prevents the long central pause from happening, even if the brain's in-tunnel drive drops completely offline.
So it literally forces ventilation during the central apnea. It just keeps the rhythm going mechanically.
Correct. It steps in when the autopilot fails.
So the pearl here for BPPST is that titration in the sleep lab is absolutely key. You cannot just blindly guess these settings and ship a machine to their house.
No, you have to carefully ensure stable breathing, and you have to ensure airway patency first with your expiratory pressure.
Right, because if you push a backup breath against a collapsed throat, nothing happens. And you also need to monitor the downloads heavily for ventilatory and chemical parameters. You want to make sure the machine isn't overventilating them and causing its own problems.
Which perfectly segues into the exact next recommendation. This is the big glaring red stop sign in the 2025 guideline, bi-level PAP without a backup rate.
Just standard BPAP. The guideline gives a conditional recommendation against using this.
Yes, against.
But why? I mean, standard bi-level is so comfortable. Patients generally love it because it feels natural to exhale. Why not just use it?
It all comes back to that loop gain and the instability of the thermostat we talked about earlier. Standard bi-level provides pressure support.
Pressure support being the physical difference between the high inhale pressure, the IPAP, and the lower exhale pressure, the EPAP.
Right. And what does pressure support do? It physically increases your ventilation. It literally helps you take a much bigger, deeper breath than you would on your own.
Okay, so you breathe deeper. That sounds like a good thing for someone with sleep apnea.
Is it? Think about the chemistry. If you breathe much deeper, what happens to your carbon dioxide?
Oh, you blow off more CO2.
Exactly. You wash out the CO2, and if you drop your CO2...
You plunge right below the hypocapnic apneic threshold, the floor we talked about.
Yes. And since there is absolutely no backup rate on this specific machine to save you...
The brain just stops breathing.
You have essentially taken a vulnerable patient and put them on a machine that is perfectly engineered to cause central sleep apnea.
That is wild. By trying to help them breathe more comfortably, you amplified the exact chemical instability that causes the disease.
It is a physiological trap. The takeaway is unambiguous here. Do not use standard bi-level without a backup rate to treat central apnea. You are very likely to make the instability worse.
If you truly need bi-level pressures to treat them, you must use the ST mode with the backup rate.
Exactly. Don't fall into the pressure support trap.
Okay, we are moving up the hierarchy. Let's talk about the heavy artillery. The absolute Ferrari of sleep machines, advanced therapies, adaptive servo ventilation, better known as ASV.
The smart machine.
Right. It dynamically learns your breathing pattern over a moving window and adjusts the pressure support breath by breath to smooth everything out.
The 2025 guideline gives a conditional recommendation for ASV.
For which etiologies?
Primary, heart failure, medication, treatment emergent, and medical disorders.
Okay, we have to pause the train right here. Because if you have been practicing sleep medicine or cardiology anytime in the last 10 years, you know the massive elephant in the room when you say the words ASV and heart failure in the same sentence.
The SERVE-HF trial.
Yeah.
We cannot discuss ASV without diving into SERVE-HF.
It was an earthquake in the field.
It was a massive, landmark, multinational trial published back in 2015. It specifically looked at patients who had heart failure with reduced ejection fraction, HFrEF.
Specifically defined as a left ventricular ejection fraction of 45% or less.
Yes, very sick hearts. And these patients had predominant central sleep apnea. They randomized them to either get optimal medical therapy alone or medical therapy plus this ASV machine.
And the results were, frankly, terrifying.
They were alarming. The study showed a statistically significant increased rate of cardiovascular mortality in the group treated with ASV.
People literally died at a higher rate when they were put on the smart machine.
Yes. So naturally, the manufacturers and the medical societies issued massive urgent safety notices. Do not use ASV in heart failure with reduced ejection fraction. That has been the absolute golden rule of sleep medicine for a decade.
But here we are looking at the 2025 AASM guideline, and it clearly says conditional recommendation for ASV, and it lists heart failure. So what on earth changed? Did they just ignore the SERV-HF deaths?
No, they absolutely did not ignore it. The Guideline Task Force performed a brand new, very rigorous meta-analysis of all available RCTs.
Including all the subgroups of patients with heart failure.
Yes. And when they pulled all of that data together, which included the old SERV-HF trial, but also included a newer major trial called ADVENT-HF, they found no significant change in overall mortality across the board.
So the scary mortality signal just got mathematically diluted when they looked at the broader, updated picture?
Partly. But the guideline is still extremely cautious here. They openly acknowledge that the SERV-HF safety signal cannot simply be waved away. But they introduce a crucial concept to explain it: algorithmic variability.
Algorithmic variability. This is so important. ASV is not a generic chemical drug like aspirin where every pill is the same.
Exactly. Different machine manufacturers use totally different, highly proprietary algorithms to run their ASV devices.
The black box inside the machine is different.
Very different. The specific brand and algorithm of the device used in the SERV-HF trial functioned differently than the device used in the newer ADVENT-HF trial.
The ADVENT-HF trial used a machine that responded differently to hypopneas, right?
Yes, it targeted different minute ventilation parameters and responded differently to changing flow. And the ADVENT-HF trial did not show that same mortality harm.
So the working hypothesis in the field is that maybe it wasn't the fundamental concept of ASV that killed people, but rather that specific proprietary way of delivering the pressures in that one trial that caused the strain on the weak hearts.
That is the leading thought. However, the guideline does not endorse one specific brand or device over another. They explicitly state in the text that they cannot make an unambiguous conclusion about the safety of every specific ASV modality because these different machines have never been rigorously compared head-to-head in a trial.
Wow. So where does that leave the practicing clinician on a Monday morning? You have a heart failure patient with central apnea. Do you write the prescription for ASV or not?
It leaves you with extremely strict implementation guardrails. First, shared decision-making is completely mandatory here. You have to sit down and explicitly explain the SERV-HF mortality data to the patient.
We cannot gloss over the risk.
No. Second, and this is bolded in the remarks, for patients with heart failure with reduced ejection fraction, that LVEF of 45% or less treatment with ASV should be strictly limited to experienced centers with close monitoring and follow-up.
So do not just casually prescribe this out of a rural primary care clinic and tell them to come back in 6 months?
Absolutely not. It requires a specialist who deeply understands both heart failure hemodynamics and complex ventilatory algorithms. You usually need an advanced heart failure cardiologist actively involved in the care loop.
But, and I think this is a vital distinction, for patients who do not have heart failure, like those with opioid-induced CSA or just plain treatment emergent CSA, that SERV-HF safety signal does not apply to them, right?
Correct. The mortality risk was specific to the reduced ejection fraction heart failure physiology. For other etiologies, the safety profile is much standard.
And for those non-heart failure patients, how well does ASV actually work?
Mechanically, it is incredibly effective.
Yeah.
It normalizes the AHI, and it completely crushes the arousal index better than almost anything else we have. It smooths out that chaotic sine wave beautifully.
So it is a remarkably powerful tool, but you have to use it with immense respect and caution, especially anywhere near a failing heart.
Respect the algorithm.
Okay, let's step away from the complex ventilators for a minute. Let's talk about something that seems much simpler but has its own quirks: low-flow oxygen therapy.
The guideline gives a conditional recommendation for our low-flow oxygen.
Who is this intended for?
Specifically for CSA due to heart failure, which is low certainty evidence, and CSA due to high altitude, which is very low certainty.
I always get questions from patients on this. How does just bleeding a little extra oxygen into the nose actually fix central apnea? I thought the core physiological problem was a lack of carbon dioxide, not a lack of oxygen.
It is about carbon dioxide, but remember the loop gain. Oxygen acts as a stabilizer for the loop gain.
Go back to the thermostat analogy.
Right. We said the sensors in the body are hypersensitive in these patients. Well, supplemental oxygen physically dampens the sensitivity of the peripheral chemoreceptors.
The sensors in the carotid bodies in the neck.
Exactly. Flooding them with oxygen basically turns down the gain on the thermostat.
So the system stops overreacting so violently to every tiny change in CO2.
It calms the whole feedback loop down, so you do not overshoot into hyperventilation and undershoot into apnea nearly as much. It specifically prevents that hypoxia-induced instability that drives the Cheyne-Stokes pattern.
That makes perfect physiological sense. What did the evidence actually show it achieve?
In the systematic review, oxygen significantly improved the AHI and the central apnea index.
Let's fix the numbers.
It fixed the numbers, but, and here is the good practice statement check again on PROs, it did not significantly improve patient sleepiness, and it did not improve the 6-minute walk distance in the pooled analysis for heart failure patients.
So they breathed somewhat better on paper, but they didn't necessarily feel more energetic or walk further in the clinic.
Exactly. And practically speaking, getting supplemental oxygen approved purely for sleep apnea is an absolute nightmare in terms of insurance coverage in many places.
Oh, it is a huge barrier. Massive. If they're not distinctly hypoxemic while wide awake during the day, Medicare and most private insurers will often just flat out refuse to pay for a concentrator for sleep.
Accessibility is a major, major issue with this recommendation. And the guideline reminds us again, reevaluation is necessary. You cannot just put a nasal cannula on them and forget them. You have to order another sleep test to check if it actually stabilized the central events.
Okay, we are moving into the often forgotten therapies now. Let's step completely away from masks, hoses, and cannulas. Let's talk about pharmacology. Let's talk about pills, acetazolamide.
The guideline gives a conditional recommendation for acetazolamide.
This is fascinating to me because this is a really old drug. Most doctors only think of it for preventing acute mountain sickness if you are climbing a mountain, or maybe for treating high eye pressure and glaucoma.
Right. It is a classic carbonic anhydrase inhibitor.
Mechanistically, how does a glaucoma pill stop central sleep apnea?
It alters your blood chemistry. It acts on the kidneys to make you excrete bicarbonate in your urine.
It makes you pee out base.
Yes. And when you pee out bicarbonate, your blood becomes slightly more acidic. It creates a mild, deliberate metabolic acidosis.
Okay, and why do we want the blood to be acidic?
Because acid is a profound respiratory stimulant. The acidic blood washes over the brainstem, and the brain interprets that acidity as a signal that says, hey, we must have too much CO2. We need to breathe more.
So it constantly stimulates breathing. But doesn't that make the loop gain worse?
Actually, it shifts the apneic threshold. By making the baseline chemistry more acidic, it makes it much harder for a mild drop in CO2 to trigger a complete respiratory pause.
It lowers the floor.
Exactly. It lowers the floor so you don't hit it as often.
Who is this conditionally recommended for?
Multiple etiologies: primary CSA, heart failure, medication-induced, and high altitude.
What does the evidence base look like for a pill?
We have 3 RCTs, but they were very short duration. We are talking about trials that only lasted 3 to 6 nights.
3 nights? That is hardly long-term data.
It is not. The doses ranged widely from 250 up to 1,000 milligrams. But in those short windows, it did successfully improve subjective sleepiness and it lowered the AHI.
But there are very real side effects. This is definitely not a free lunch.
Oh, not at all. You get paresthesia.
The very annoying tingling sensation in the fingers, toes, and lips.
Yes. And taste changes are huge. It alters how your taste buds perceive carbonation.
So a patient goes to drink a soda, and it tastes like terrible metallic battery acid.
It sounds funny to us, but ruining a patient's favorite Diet Coke can absolutely be a deal breaker for adherence to a daily medication.
Oh, totally. And diuresis, it makes you pee constantly, especially at night.
Which disrupts sleep.
So the host pearl for clinicians here. If you are going to trial acetazolamide and you use it for 2 to 4 weeks, you absolutely must bring them in to check their blood labs.
Yes, you have to run a basic metabolic panel. Because of the deliberate acidosis and the diuretic effect, you can really mess up their potassium levels and their overall acid-base balance. It requires active medical monitoring.
Finally, we have reached the end of the line, the most advanced option on the table, the cyborg option, transvenous phrenic nerve stimulation, TPNS.
The guideline gives a conditional recommendation for TPNS.
This is specifically for primary CSA and CSA due to heart failure, right?
Correct. This is a genuinely fascinating futuristic technology. It is a surgically implantable device. It looks and acts sort of like a cardiac pacemaker.
But it doesn't pace the heart.
No, the electrophysiologist threads a pacing lead into a specific vein, usually the pericardiophrenik vein or the brachiocephalic vein, right next to the phrenic nerve in the chest.
And the phrenic nerve is the wire that tells the diaphragm to move.
Exactly. So the device monitors your breathing while you sleep. If it senses a central pause, it literally zaps the phrenic nerve to artificially cause the diaphragm muscle to contract.
It literally paces the breath. Breathe, breathe.
Breathe. It physically bypasses the sleeping brain entirely and commands the lung bellows to pump.
That is incredible. What did the evidence show for this?
The evidence comes from one major RCT, the pivotal trial, plus some longitudinal observational studies. It showed significant, durable improvement in the central apnea index, and it actually showed improvements in quality of life metrics.
But I know there is a massive but coming.
But the certainty of the evidence is very low across the grade domains, and practically it is extremely high cost.
Tens of thousands of dollars.
Yes, and it is invasive. It requires a surgical procedure in a cath lab, and it requires specialized cardiology and electrophysiology infrastructure to implant and program the device.
You cannot just write a script for this in a standard strip mall sleep clinic.
No, you have to refer them out to a highly specialized center.
And candidate selection for this surgery is absolutely key. You have to get this right.
It is crucial. TPNS is only appropriate for patients who have very few obstructive events.
Why is that?
Think about the mechanics. If the patient's throat is collapsed, if they have obstructive sleep apnea, and the implant zaps the diaphragm to pull a breath.
The diaphragm pulls hard against a totally closed, blocked throat.
Exactly. It is like trying to suck a thick milkshake through a totally pinched straw. Nothing happens except you wake the patient up in distress. TPNS only treats the central drive failure. It does absolutely nothing to stent open a collapsing airway.
So if they have mixed sleep apnea with a high obstructive component, this expensive implant will essentially fail them.
Exactly. You have to carefully phenotype their sleep study to ensure it is predominantly pure central apnea before you ever send them to the surgeon.
Okay, we have thoroughly covered the waterfront here.
Yeah.
We went from the basic physiology to the dangers of standard bilevel to the incredibly nuanced smart machines to altitude drugs all the way up to surgical implants.
It is a lot to digest.
Let's wrap this entire thing up with a clean synthesis. Let's go back to that very first scenario. It is Monday morning. That messy download is sitting there on your screen. Based entirely on this 2025 AASM guideline, what is the actual clinical pathway?
Let's lay it out. Step 1, optimize.
You have to treat the underlying contributors first. Treat the heart failure aggressively. Adjust the pain medications or taper the opioids. Fix the underlying medical condition if you can. Do not skip this step.
This is the good practice statement in action.
Step 2. Start feasible.
Often, that means your first line is a trial of CPAP, simply because it is sitting right there in your lab, the staff knows how to use it, and insurance will usually cover the initial trial. It might fix the subtle obstruction and stabilize the lung volume enough to cure the central instability.
Step 3. Verify.
Check the actual machine data. Did the central events go away on CPAP? Or is the device still flagging a high central index? Do not assume it worked just because they are wearing the mask.
Step 4. Pivot.
If the central sleep apnea persists despite optimization in CPAP, do not just leave them on it. Reassess the whole picture.
Step 5. Escalate.
This is where you move to the specialized therapies based on the patient's exact etiology. Move to ASV, but with extreme caution and specialist monitoring if they have HFrEF.
Or consider bilevel with a backup rate if you need to enforce ventilation.
Think about prescribing low-flow oxygen or a trial of acetazolamide, or if they are an appropriate candidate with pure central disease, refer them out for a TPNS implant evaluation.
And at every single step of that pathway, you must prioritize the patient-reported outcomes.
Right. If the AHI number on the screen looks pretty, but the patient sitting across from you is still miserable, sleepy, and functionally impaired, you have not succeeded. The job is not done.
And remember the reality check you gave us at the beginning. Almost every single recommendation we discussed today is graded as conditional.
The evidence is limited, and that reality puts the heavy burden squarely on you, the clinician, to actually talk to your patient.
To share the decision-making process, to explain the risks, the benefits, and the deep uncertainties of these therapies.
The guideline gives us a map of the gray zone, but the clinician still has to drive the car.
And not reported in the guideline applies to a lot of specific clinical situations you are going to face. Your clinical judgment remains absolutely essential.
Medicine is still an art.
That brings us to the end of this deep dive into the 2025 AASM Central Sleep Apnea Guidelines. We really hope this detailed breakdown helps you navigate that next messy patient download with a bit more confidence.
There is always more to learn in this field.
If you enjoyed this deep dive and found it useful for your practice, make sure you hit subscribe so you do not miss the next one.
And please send us your topic requests or any corrections. We genuinely love hearing from the community.
And I will leave you with a final thought to mull over today. As algorithms in these ASV machines and implants get smarter and rely more heavily on artificial intelligence to predict central pauses before they even happen, are we eventually going to reach a point where the machine understands the patient's individual loop gain better than the physician reading the report ever could?
That is a provocative thought.
Thanks for listening. Go treat the patient, not just the number.
Thank you for spending your time with Prism Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.